Hello and welcome. On behalf of CME Outfitters, thank you for joining us for today's CMEO briefcase titled Applying Patient-Centered Pain Care to Practice, a case of long-term opioid use in primary care. Today's program is supported by an independent educational grant from opioid analgesic REMS program companies. I'm Melissa Weimer. I'm an associate professor of medicine and public health at Yale School of Medicine and Yale School of Public Health. I'm also the medical director of the Addiction Medicine Consult Service at Yale New Haven Hospital in New Haven, Connecticut. And I'll be moderating today's briefcase.
So I'm Kathleen Broglio, and I am an associate professor of medicine at Dartmouth-Hitchcock Medical Center and work in the palliative care department as a nurse practitioner, working with people with serious illness that also have complex pain and risks for or substance use disorder. And I come from a background of pain management, and I'm going to be presenting the case and talk to you today about principles of opioid prescribing in long term.
The goal of this educational activity is to empower learners to incorporate the updated CDC guidance for prescribing opioids to practice for safe and competent prescribing and improve health-related quality of life for patients with chronic pain. Dr. Broglio, can you tell us about the case?
Yes, so this is Randall, and he's a 67-year-old man that's coming to your practice, and he's establishing care for his long-term back pain. He's had back pain for over 10 years and has been on chronic opioid therapy that was previously prescribed by his primary care provider, who retired. He transferred care to a new primary care provider who told him he would not continue opioids and planned to rapidly taper opioids and only prescribe non-opioid therapy. So he's coming to see you to establish care. You're getting ready to see him and you're reviewing the medical history, and this is what you see. You see he has coronary artery disease and had an NSTEMI 2 years ago, has obstructive sleep apnea and uses a CPAP. You note that it says he has daytime hyperinsomnia and depression and anxiety. When looking at his medications, you see he's on pretty high dose opioids with a total morphine equivalent of more than 200 milligrams daily. And you see that he's being treated for his depression and anxiety with an SSRI, but you also note that he's on a benzodiazepine. So you're starting to think about what are you going to worry about and what are your concerns and what are you going to want to know more about when you do meet Randall. And hopefully you will have obtained his previous records from his former primary care provider, and you would have checked the prescription drug monitoring program before seeing him. So I'm going to turn it back to you, Dr. Weimer, to ask the audience a question.
So which of the following should be reviewed first with Randall when discussing chronic opioid therapy? Think about the options below and determine what you think the correct answer would be. So the correct answer here would be A, current impact of pain on his daily function and activities.
So before we go back into talking more about how we're going to approach Randall, let's talk about the 2016 CDC guidelines for opioid prescribing and some of the unintended consequences, and we'll then transition to the guidelines that came out in 2022. So these guidelines came about to really help improve, we hoped, opioid prescribing for chronic pain and decrease the unintended effects of opioid overdoses. But there were unintended consequences that happened. On a patient level, many patients with chronic pain on opioid therapy were discontinued from treatment, dismissed with care without a follow-up plan, even if the benefits of opioid therapy outweighed risks. And you all of a sudden saw practices coming up saying, we don't accept patients with chronic pain on opioids. We won't fulfill opioid prescriptions. I'll see you, but we'll start tapering immediately. But they were also applied in the legislative area, with 40 states enacting legislation related to opioid prescription limits, and 11 states had laws that limit daily allowable doses, and many insurance plans limited coverage. And it had this unintended consequence that you saw patients with worsening mental health conditions, and it may have contributed to some unintended overdoses and suicides. And I wonder, Dr. Weimer, did you see anything in your practice afterwards? Because I definitely did in my practice.
Yeah, I definitely think that we saw individuals who were unable to obtain care for their chronic complex pain, and certainly individuals who were on higher doses of opioids certainly had difficult with access to getting adequate treatment. So I do think that there were definitely some unintended consequences, as you stated. And ultimately, what I think, I think why this occurred was that we don't really have great education for folks on complex pain, how to manage it, how to prescribe safely, how to deprescribe or to taper individuals if we see that they are on high doses and we think they're being negatively affected. So certainly there were a lot of gaps that were uncovered, and I think we can do better. And I hope with the 2022 guidelines, we'll see some improvements in care and access.
Yeah, and I was really excited to see some of these key changes in the 2022 guidelines. And I think the most important one is on the focus on flexible, individualized, patient-centered care. Trying to take back that cookbook type approach that no one can be on over this many morphine equivalents of opioids, and this is what you need to do. And it really emphasizes really integrated pain management and collaborative working relationships among clinicians, and really delineates what is the difference in that patient that you may be initially starting on opioids versus this patient like Randall that we see that you're inheriting that's been on 10 years of long-term opioid therapy. Something that I see in my own practice, that I'm inheriting people that have been on opioid therapy for 10, 12, 15 years, and it's not going to be possible to adhere to what the guidelines were in 2016. And really emphasizes really monitoring risk versus benefit and patient education. So let's go on to looking at like what would be an opioid prescribing workflow. And this workflow is one that I use in my practice. Even though I work in palliative medicine, we utilize universal precautions for opioid prescribing, even among our patients with cancer who might be undergoing treatment or have advanced disease, because they're just as much at risk to develop risky opioid use or substance use. And it really starts with doing a good comprehensive pain assessment. So even if I was meeting Randall for the first time and it said he had back pain for 10 years, I'm still going to want to do a full assessment. What kind of back pain? Has he had surgeries? Has he had recent diagnostic imaging? If the pain is worsening, do I need to re-image again? Am I going to do an opioid risk assessment? Absolutely. Even if he's been on opioid therapy, I've not met him before. Do I need to know, is he drinking alcohol? Does he have a family history? I'm going to have checked the prescription drug monitoring program in my own practice. We check it actually prior to every prescription. And I would obtain a urine drug screen to make sure that he is taking what he says he's taking, and to make sure that he may not be taking what I was not prescribed. And then using informed consent and a patient provider agreement. I don't use the word contract. This is not a legally binding agreement, but it's an agreement that we have with each other. And then I'm going to want to establish, what is the goal? Like, what does Randall want here? Is he looking at increased function? But I'm also going to look, when I look at this case of Randall, I see opioid only therapy. So I want to think about what are the other things that I can add in terms of non-opioid, non-pharmacologic therapies. Now, if the patient I'm seeing is opioid naive, which means that they're on less than 60 milligrams of morphine equivalent, and I decide to start a trial, and I think about someone I recently started, she was actually referred to me for goals of care, severe aortic stenosis, 81 years old, but has severe facet arthropathy. And it has been referred to pain management, but it's a 6-month wait. Right now, she lives in assisted living. She can't even get out to have meals with her residents because the pain is so severe. She's on maximal doses of acetaminophen. I can't use NSAIDs because of her cardiac history. And she's also has comorbid depression and anxiety and is on SSRIs and antipsychotics. So really thinking about other non-opioids is not a possibility. So this is someone that I might decide to try something like a low-dose buprenorphine patch for opioid naive and see. If it was someone like Randall and I'm seeing him for the first time, then I may decide to continue the same thing if there's no red flags, because as a primary care provider, I may only have 20 minutes with him for a new visit. And I may just say, okay, I'm going to refill these prescriptions, do the treatment agreement, the urine drug screen, and then reassess. But then I'm going to see that person back if I'm initiating or it's new, probably in 1 or 2 weeks. The benefits of telehealth now is that I'm able to see more people because I can use telehealth. And I'm going to look, is there a positive outcome? So for example, the woman with the buprenorphine patch, 2 weeks later, she tells me she's walking out to have meals with the residents. She's actually going to an exercise program. She's got some constipation, but that was pre-morbid, but she's not having any adverse effects. And so I may decide, wow, this is moving toward. Say with Randall, say I continued him on his treatment, and 2 weeks later, he's telling me he's out of his hydrocodone acetaminophen, and I prescribed a month of supply. I just renewed for a month. Then because I said, well, he's been on this prescription drug monitoring program, looks okay. I prescribed a month, and he's telling me 2 weeks later he ran out. Well, his pain got a little bit worse, so he took a little bit extra. Then I may need to revise my plan then and think about what are my next steps. I didn't know if you had anything else you might want to add to that, Dr. Weimer, in terms of your practice.
Yeah, I think a lot of what you talked about was really doing your due diligence. What I see when I encounter patients for the first time is a lot of them really haven't had a comprehensive evaluation of their pain. They don't really have a diagnosis, a specific diagnosis. They've maybe been given the diagnosis of low back pain, but otherwise it's not further described. I think many times there's not an appreciation of how this pain is affecting their function. So really fully assessing that, as you discussed, I think is really important. There's a lot of focus on the medication, but less on the actual pain and are they really receiving good pain care? And I think the other thing that sometimes happens for people who have pain is there's this focus on opioids only, as you discussed, and really not thinking about the other treatments that can be very, very successful. So certainly when meeting somebody for the first time, I want to make sure they understand that pain has a lot of different treatments. Opioids are one of them, and we have many other things that can be safely provided, and really helping determine what is their functional state, how can we help them be more functional. And for the patient you were describing, the 81-year-old woman, you know, that's wonderful that she was able to go from really being pretty isolated, which also worsens pain, to then being able to be more functional. So that is what good pain care can provide to people. And I think that sometimes gets lost when we focus only on opioids.
Yeah, and that brings us to really thinking about this comprehensive pain and risk assessment. And I think you brought up the whole thing about like, if I could throw out the 0 to 10 scale, I would. I think it's great for acute pain perioperative. But when I'm thinking about someone with chronic pain, I want to know what can you do now that you couldn't do, or what can't you do now that you could do, and really that patient history, the exam, thinking about diagnostic studies, but also what's going on, where does that person live? Who do they live with? Who are their support systems? Because I'm also thinking about like, okay, especially with my older patient, like, okay, are there teenagers, young adults in the house? Do I need to worry about risk for diversion or risk, do I need to worry about that? So or also who may be helping manage the medications if I'm thinking about prescribing opioids. Like for this 81-year-old lady, I wasn't as worried because she's in assisted living. Once a week, the nurse is going to be putting that on her. If she was alone, maybe I would have to think, is there a dedicated caregiver that would come in? And I think and when we think about this U.S. Department of Health and Human Services, their pain management best practice interagency task report from 2019, I think was a great document that really looked at the updates, the inconsistencies and recommendations. And I think it was overlooked because everyone focused on the 2016 CDC guidelines. And this, which really kind of focused on looking at, multimodal care and not just putting this hard stuff, not even focusing on we can't use opioids except. I think that it really kind of addresses that multimodal can include opioids. And even though we don't have a lot of evidence, we don't have a lot of evidence for a lot of things we do for pain management, but we do know that multimodal does work best. So I think patient education is really important. I really talk about people, yes, I want your meds locked. I know we think we say preferably. I really say, I really want you to have a lockbox. And no, storing it in between your mattress is not a good idea, or in the master bathroom. And I say that because I've had patients who said, no, but I had it in my mattress and the only one who came over was my niece and nephew. And I'm like, and here's someone with stage 4 prostate cancer and like cannot go without opioids, but again, wasn't keeping it secured. Obviously, where to dispose of, and although all the opioids are on the FDA flush list, I live near the Connecticut River up in New Hampshire. We really didn't want the opioids in our river, so we tried to have it. Most towns had police stations. You could take it back. A lot of pharmacies now have places. There are some mailboxes, and the most important thing is making sure that people have naloxone for opioid reversal now, and that people that live with them know how to administer it. And if they live alone, well, that's a little bit of a challenge because I'm a patient. Well, I live alone. They find me, I'll be dead. But is there someone, is there a neighbor, is there a caregiver that can be educated about it? So I'm going to turn it back to you, Dr. Weimer, because I think we have another question.
Yes, so our second question is, which of the following is a potential indication for tapering Randall's chronic opioid therapy? So think through the options here and pick which one you think is the appropriate answer. So the correct answer here would be answer D, reports of daily uncontrolled pain episodes.
And so let's go back to the case of Randall. So you've gone in to see him, and he tells you he's been on oxycodone, hydrocodone, acetaminophen for years and never changed the dose. He doesn't get out much to exercise, some walking, but usually just stuff around the house. And he's not been involved in any physical therapy program for at least a year. He really tries to take it easy because, he doesn't want to damage his back more. Yeah, he got diagnosed with sleep apnea about 3 years ago and was given a CPAP. And he tells you it's really uncomfortable. So it sits at his bedside table. And yeah, he puts it on once in a while, but not often. He has mild depression, according to his PHQ-9, and minimal anxiety. And he tells you that sometimes his depression makes doing things difficult, but you don't really probe and you don't really know if he's actually been in psychiatric care. But right now, this is what you're seeing. But you do ask, and he says he's never had any suicide attempts in the past. He tells you on a typical day, he takes his hydrocodone 2 to 4 times. And the records show that he had a trial of gabapentin about 2 years ago. But when you ask him, he had no clue. But he does tell you that when they tried to taper his opioids after he had his myocardial infarction, that he did experience withdrawal symptoms, and it was pretty bad. And he tells you he's done well on his opioids. He's never had an unintentional opioid overdose, and he doesn't really have any adverse effects from it. So when we think about our chronic opioid treatment visit, like what should be the essential components? One, we need to see people at regular intervals. I'm going to tell you in my practice, I see people every month, unless they're on something like a low dose buprenorphine patch and they're really stable, or it's someone that's been on long-term treatment and really, really stable. But otherwise, our guidelines really in our clinic is every month. I track function scoring at every visit. The nurses might take the 0 to 10. That to me is just not, I know when I worked in chronic pain in New York City at a chronic pain clinic, everyone was always telling me they were an 8 to 10. And, when I asked someone once, he says, no, but because if I tell you my doses, my pain is lower, you're going to reduce my therapy. You're going to reduce my opioids because that fear being taken away. I'm going to evaluate for risk of harm. Asking about ED visits, looking for if I can see if there have been ED visits, if they're within our system, talking about non-opioid therapies. That's something I'm going to try to bring up. And really, what is my plan? Are we going to continue? Are we going to adjust? And are we going to taper? Are we going to stop the opioids? And are we going to need to have a specialist referral? So this is something that should be in my visit components. And I don't know, Dr. Weimer, if you have other things that you think about in your own practice.
No, I think those are many of the same things that I think about. Many of the patients I see have high risk features that I might think about, asking about substance use or doing other screenings, such as risk evaluation, urine drug screening, and thinking about the timing to do that. So I think it depends on who you're treating, who is your patient, what additional modalities of risk mitigation might you think about if you are prescribing opioids.
Yeah, and I was going to say, part of my every visit is really checking the prescription drug monitoring program. And then everyone has done an opioid risk assessment in our own clinic based on, okay, this is someone who's high risk. We might be doing a urine drug screening in the beginning every month, or we may, versus someone who's very low risk, we might only do it once a year unless something changed, and also it really depends on your state guidelines, because some state guidelines are actually mandating when you should potentially be doing that type of screening. So when would we consider tapering opioids? Well, maybe, the patient comes in and requests it, I would love if that happened on a regular basis in my practice, but it generally has not over the last 2 decades. Um, or there's really no pain reduction or improvement in function with opioid use. And I think about someone I saw who really was not progressing towards anything and was getting more somnolent. And then if we think about safety concerns, okay, on medications that increase risk of overdose. So I'm automatically thinking about this with Randall. He's on benzodiazepine, he's overweight, he has sleep apnea, so we have a lot of risk to it. If there's a reported overdose or there's non-adherence, like the patient has called, says, well, yes, I mean, yes, I ran out early of my immediate release because, I had, a crisis. Well, no, I didn't think to call you, but, this is what happened. The other thing I'm thinking about, especially with my older patients, is that is there worsening chronic disease in terms of renal disease? I think I worry more about sleep apnea and my lung disease. Am I increasing my risk for overdose? And are there mental health conditions that can worsen with opioid therapy? So, I don't know this about Randall. Like, I don't know if the depression preceded the back pain or came afterwards, or if it was associated with his myocardial infarction, but all those things can play into considering tapering my opioids. Well, let's go back to Randall for a moment. He tells you, listen, I'm comfortable with this medication regimen. I've been on this for years. I haven't increased the dose. I've never had any adverse effects. I'm doing well on it. So some of the benefits to continuing is that he's been stable long term on it. You've checked the prescription drug monitoring program. You don't see any changes in terms of early refills. Seems to be low risk. He's not drinking alcohol. And your relationship is new. And so you may decide, well, I don't know if I should make that change. But on the other side, you're worried about the lorazepam use. You're worried about sleep apnea and the fact that the bedside table is getting the CPAP, not him. And I see that so often. Yes, I'm on CPAP. How much are you using it? It's never mind if you have CPAP. How are you using it? I also worry. I would want to know more about the depression history. And thinking about, is it worsening? And then I think about the fact that he's had a myocardial infarction, and he's at risk to progress to congestive heart failure and increasing complications. And I don't really know yet if he's not meeting functional goals, but it sounds like he's pretty sedentary. So these are things I might say, gosh, the risks are outweighing the benefits. So I'm going to approach him about potential tapering. And I wonder, Dr. Weimer, what your thoughts are. Would you consider doing it on a first visit?
Think it's pretty challenging on a first visit, quite honestly. I think, you want to be able to build rapport. You don't want him to walk out and not seek any care from you in the future. So unless I see very severe risks where I don't feel like I can prescribe to him under these circumstances, I generally, have a tincture of time where I'm getting to know him, building rapport, because the worst thing would be that he just doesn't engage with you at all. You're not able to provide him any care. So I don't think that's good medicine, and that's not what we're trying to achieve. I think you are setting up, like you said, that evaluation of risk versus benefit. And so you can openly talk to him about that and just let him know that you are seeing a lot of risks that you're concerned about, see what he says about that. And that, again, creates that transparency, develops that rapport, so he knows that you're really looking out for his best interest. It's not just because you don't like the therapy he's on. Certainly, if I were to see him for the first time and I'd be concerned about, say, an opioid use disorder, that's not the case here. But say I see him and I do get that concern, that would be a situation where I would not potentially prescribe to him, and I would offer medication treatment for opioid use disorder. But that's not the case here. I think definitely building that relationship, as it sounds like you're planning to do.
Yeah, and I agree. I mean, if I think if this was my patient in clinic, unless he was on board with it, I probably wouldn't do anything that first visit because, he'd already had a negative experience trying to go to a new PCP. But say in this case, Randall says, okay, yeah, I'm willing to try it and see if it works. And so, you decide to taper and you look at the guidelines and you decide to do the 10% a week because you looked at the guidelines. And so you started him. And in week 1, you did the oxycodone extended release 80 milligrams in the morning, and then you decreased to 60 milligrams at night. And you continued it as acetaminophen hydrocodone at the same doses. And then week 2, you went down to 60 milligrams every 12 hours. And he comes back and he's telling you he's tachycardic, he's got abdominal pain, his back pain is worse. He's sitting around all the time now, and he's getting more depressed. And now the lorazepam that he was using maybe 2 or 3 times a week, he's using every night. So you see that from that visit that you went the wrong way, or you potentially tapered too quickly. And that comes to, like, when we think about tapering, we really need to think about going slow, especially if this person has been on long-term opioid therapy. A decrease of 10% is reasonable starting, but in my own practice, I find that if they've been on long-term therapy, even 5% may be the right way to start, and 10%, maybe even every month. And we have to say that if we go back up, that we have to then talk about the fact they may have lost some tolerance and the risk for overdose increases. And we want to see about, if we're going to taper, can we consult with other specialists if needed, especially if they're at risk for harm, or if when we start tapering, we unmask an opioid use disorder that was maybe masked by the fact that we were prescribing, opioids for pain. And then we want to try to link to psychosocial support if it's available in your area. Already should have been on naloxone, but we really want to watch for worsening signs of anxiety or depression, because the last thing we want to do is unintended harm and put this person at risk for suicidal ideation. And then really talk about the withdrawal symptoms. And we have to talk about that if someone's been on long-term opioid therapy, whereas the withdrawal symptoms for physical may resolve in 5 to 10 days, but the psychological withdrawal can go on for months, and really be honest with the patient that the pain may worsen for a little while before it gets better. Maybe in the case of opioid-induced hyperalgesia, it may get better, but for other patients, we need to be honest and prepare them for that. And so when we think about some opioid tapered examples, we see there's been no randomized controlled trials that I know of to look at what's the best, but there's 4 examples on this slide that show the slowest taper that can be 2 to 10% every 4 to 8 weeks. And this is some of the things that I do for some of my patients that have been on therapy for more than 10 years. And I may take some pauses, like, oh, Christmas is coming up. Can we take a pause this month? Or a slow taper 5 to 20% every 4 weeks. And that's the most common. I still think probably 5 to 10% in my own practice. I think 20% for someone who's been on long-term opioid therapy, pretty high dose, might be a pretty dramatic. When we think about a faster taper, 10 to 20% every week, that's usually if I have some concerns about aberrant behavior or really adverse effects that I'm really worrying about. And when I'm talking about a rapid taper, 20 to 50% and 10 to 20% every day, this is my patient that may come in with no opioids in their urine on a urine drug screen. And then they says, oh yeah, well, they binge and use their opioids in the beginning of the month and then they run out. Or we see that, there's, frankly, aberrant behavior, and that may force a rapid taper in that way. And I wonder, Dr. Weimer, if you have anything you want to add to this.
No, I agree with that. I think whatever your approach, it should be individualized to the patient. I do think any sort of rapid taper, you need to be prepared that your patient's going to have opioid withdrawal symptoms, which can be quite profound. And so there are, certainly mechanisms to reduce the opioid withdrawal feeling. And some of those could be buprenorphine as an alternative treatment, or considering utilizing a lot of adjuvant therapies. And then I also worry about overdose risk with a very rapid taper. So making sure that people are aware that their tolerance will they will be at risk to have an overdose if they abruptly go back up on their dose.
Right. Yeah. So the plan moving forward, so he agrees to go ahead and try the opioid taper again. And we're going to really target maybe 5% per week. And we may even slow it down more depending on his response. And so we go back to that week 1 of oxycodone extended release, 80 in the morning, 60 in the evening, and keep the hydrocodone and acetaminophen. We do stop the lorazepam because we're still worried about that, and think about another therapy to help with anxiety or for sleep. And then we really reinforce the overdose prevention, as you brought up, and we think about referring to a psychiatrist if needed, especially if we're thinking this is long-term depression. But say we find out that he was really put on his escitalopram after he had the myocardial infarction, because he ended up with depression after his myocardial infarction. And he's really been stable, never had depression before. And this may be the time you might think about rotating to something like duloxetine, which may treat not only depression, but it's also FDA approved for musculoskeletal pain. We also may want to think about, like, if there is a neuropathic component of his pain, would something like a gabapentinoid be a possibility? But I still also worry about that, because we know that we see with comorbid use of opioids and gabapentinoids, there is still an increased risk of gabapentin. And finally, you brought up, Dr. Weimer, this would be like the ideal candidate. Gosh, I would love to get him on buprenorphine therapy for his pain therapy. It's really probably my number one choice, because it's going to be safer in terms of risk for opioid-induced respiratory depression, won't increase, it won't, it may reduce his tolerance, and just safer overall. So I'm going to turn it back to you, and thank you for letting me present this case. Dr. Weimer?
Yes, thank you. A lot of great insight there, and thank you for you sharing real life cases and talking us through that case. I think we've all learned something today. So let's put it all together with our SMART goals to apply in practice. After today, we hope participants will complete a comprehensive assessment in patients who have chronic pain, identify risk factors for unintentional opioid overdose in patients who are prescribed chronic opioid therapy, use shared decision-making to develop treatment goals for patients who are prescribed long-term opioid therapy. So we have multiple other CMEO brief cases that we hope you will participate in. Be sure to check out the next one listed here. So the next one is a case of unexplained pain onset. Then we have a case of unrelenting post-traumatic pain. And then our final case, a case of chronic pain and opioid use disorder. These activities, as well as many other educational activities for clinicians and patients, can be found online at the CME Outfitters Opioid and Virtual Education Hubs. You can see the links here. To receive continuing education credit and a printable certificate for completing today's activity, participants must complete the post-test and evaluation online. Thank you all for participating and providing the best care for your patients. Thank you so much, and take care.